Here is the apparent contradiction. Why do many protocols continue vaginal progesterone until 34, 36 plus 6, or 37 weeks, while the strongest recommendations resist starting progesterone after 24 weeks? If progesterone is still being given at 34 weeks, why not begin it at 34 weeks? This is exactly the kind of question that should make a resident pause. It sounds like a contradiction only because two different questions have been collapsed into one. Starting treatment and continuing treatment are not the same evidence claim. Starting treatment asks, if we identify the patient now, at this gestational age, can a new progesterone regimen still change the trajectory toward early delivery? Continuing treatment asks, if treatment was started in the evidence window, should the evidence-based regimen be completed until the protocol stop point? Those are different questions. The randomized short cervix trials generally began in the mid-trimester. Fonseca screened at 20 to 25 weeks, randomized women with a cervix 15 millimeters or less, and gave 200 milligrams vaginal progesterone nightly from 24 weeks to 33 plus 6. Pregnant enrolled women at 19 to 23 plus 6 weeks, used 90 milligrams vaginal gel daily, and continued until 36 plus 6, rupture of membranes, or delivery. Optimum started around 22 to 24 weeks and continued to 34 weeks.
So, when a patient started treatment at 21 or 22 weeks and is still taking it at 32 weeks, the clinician is not claiming that new initiation at 32 weeks has been proven effective. The clinician is completing a regimen that began when the patient resembled the evidence population. Now look at late initiation. The Einum study from 2025 is valuable because Norwegian guidelines allowed treatment initiation across a wide interval, from 16 to 31 weeks in pregnancies with a short cervix. The study divided diagnosis and treatment timing into 16 to 21 weeks, 22 to 27 weeks, and 28 to 31 weeks. In the full sample, progesterone was associated with lower risk of birth before 28 weeks, 0.8% versus 3.4%, adjusted relative risk 0.25. But the timing gradient is the teaching point. Among mothers diagnosed from 16 to 21 weeks, the adjusted relative risk for birth before 28 weeks was 0.13, and for birth before 34 weeks, it was 0.27. That is the strongest signal. From 22 to 27 weeks, the estimates still pointed toward possible reduction, but they were imprecise. Adjusted relative risk 0.42 for under 28 weeks and 0.68 for under 34 weeks, with wide confidence intervals. From 28 to 31 weeks, there was no apparent benefit. For birth before 34 weeks, the adjusted relative risk was 1.30. For birth before 37 weeks, it was 1.14. The memory is not just late is bad. The memory is effect gradient by timing. 16 to 21 weeks, strongest signal. 22 to 27, uncertain and imprecise. 28 to 31, no apparent benefit. The biology makes this plausible. If the goal is to prevent very early delivery, then a patient first detected at 29 or 30 weeks has already passed much of the extreme preterm interval. The process may also be closer to established cervical remodeling, mechanical stress from the growing fetus, or functional progesterone withdrawal that exogenous progesterone cannot easily reverse. Late diagnosis also changes the endpoint. A patient diagnosed at 30 weeks cannot have a birth before 28 weeks. That endpoint is no longer available. The clinical question becomes different. Can we prolong pregnancy? And by how much? That is why the late start studies that measure diagnosis to delivery interval are so important.
Dominsky and colleagues studied singleton pregnancies with no prior preterm birth and cervical length less than 25 millimeters, diagnosed between 24 plus 0 and 33 plus 6 weeks. In a 1-to-1 matched analysis, vaginal progesterone did not reduce spontaneous preterm birth at any threshold. Under 37 weeks was 29.3% with progesterone versus 26.2% without. Under 34 weeks was 7.0% versus 8.2%. Under 32 weeks was 3.9% versus 4.7%. Under 28 weeks was 0.4% versus 1.6%. The interval from diagnosis to delivery was also essentially the same, 48.6 versus 49.5 days. That last number is memorable because it answers the continuous outcome question. If you start late in this low-risk, no prior preterm birth phenotype, the study did not show that you gain time.
The 2026 American Journal of Obstetrics and Gynecology Maternal Fetal Medicine abstract asks a similar question in asymptomatic singleton pregnancies first found to have a cervix 25 millimeters or less after 24 weeks. It also found no reduction. Birth before 37 weeks was 24.6% with progesterone versus 19.1% with expectant management. Birth before 34 weeks was 3.1% versus 5.6%. Time to delivery analysis showed no difference, with a hazard ratio of 1.28 and a confidence interval from 0.65 to 2.54. Use that abstract cautiously because it is an abstract source, not a full-text conversion in the corpus, but its result supports the same teaching point. Late initiation in an asymptomatic late short cervix phenotype has not shown a clear time to delivery benefit. Now add the high-risk prior preterm birth late short cervix population. Luxenbourg and colleagues studied women with a history of preterm birth and cervical length 25 millimeters or less diagnosed after 24 weeks. This is a different phenotype. The study suggested lower spontaneous preterm birth before 37 weeks, 31.2% versus 42.8%, and no births before 34 weeks in the treated group versus 7.1% in the untreated group. But the adjusted hazard ratio for delivery before 37 weeks was not statistically significant, 1.539, with a confidence interval from 0.79 to 3.02. The study is retrospective and vulnerable to confounding, so do not generalize it as proof. Store it as hypothesis generating in a high-risk phenotype. Now return to the original paradox. Continuing progesterone until 34 or 36 plus 6 weeks is not the same as starting progesterone at 34 weeks. Continuation belongs to a regimen that began in the evidence zone. Late initiation asks whether a new treatment can still alter biology and gain time after the risk signal appears late. That is the memory structure. 24 weeks is not a magic doorway in the cervix. It is an evidence boundary. 34 or 36 plus 6 weeks is often a protocol stop point. Do not confuse the evidence boundary with the stop point. A careful physician can say, we have good evidence for starting vaginal progesterone in the mid-trimester short cervix phenotype. If it was started then, continuing to the regimen's stop point is protocol completion. But if the cervix is first found short after 24 weeks, especially after 28 weeks, the evidence for starting is weaker, observational, and in several studies negative for prolonging pregnancy. That sentence is harder than a rule. It is also the truth.